incompatibility question is really not a good question to ask.
Yeah, other comments and thoughts from Mark?
So are you agreeing with this, that it should not be included?
I think that's where we're hearing is that we removed it because it wasn't that critical an issue, and they want us to put it back in.
Okay, so you're saying that more than likely there would be a delayed response and your chances of capturing an adverse event would be low. Is that what I'm hearing?
Yeah, we don't want to imply that a hospital should report an RH incompatible transfusion as a major adverse or sentinel event, because it isn't. RH incompatible transfusions happen all the time. And I think what we were aiming at in the data element here is ABO incompatible transfusions, which are a sentinel event and a big deal.
Okay.
Right. And this is Henry, and just to add a little bit to that, since this is the surveillance version, if someone's doing chart review as surveillance and they're looking for RH incompatibility, what I'm hearing is they're going to be spending most of their day recording RH incompatibility that's not significant, because either giving platelets or plasma or blood, the current practice is that you can give RH incompatible units and it's okay.
Correct.
So our recommendation will be basically that we won't add it back in.
Yeah, correct.
Yeah, if you're doing surveillance for serious events, you want to detect ABO incompatible transfusions because those are serious events.
Sure.
Whereas RH incompatible transfusions are common and clinically indicated in many cases.
Got it. Okay.
Ira, did you have anything to add before we move on?
Oh, that's fine.
Thank you.
Okay. Let's move on to the next comment, 1.1.3.2.1. They've suggested adding the following exclusions for the administration of these agents: order for another condition, and it is a pre-existing order. Any thoughts about that?
Dave, this is Matt Grissinger. I think that kind of was in the intent of this form. If you move up the hierarchy, we're talking about an adverse event from blood product is transfusion reaction, and then below that is, because of the transfusion reaction, they got epi and corticosteroids. So adding those two other things is kind of it's not going off track, but assuming we're asking the question correctly based on the order of the questioning. So I'm not understanding why they want to add those two.
I agree, Matt. That's Shannon.
I agree. This is Nancy.
Any disagree? If not, then the recommendation would be not to add these exclusions. Thank you. The next is let's move on. Any other thoughts?
Are we muted? No. We have a question here from comment from Mark.
Yeah. So this is Noel Eldridge from Mark. So these ones, is this one that you put in, Ira? Are you on the phone?
Yeah, because we were getting a lot of false positives.
Yeah, exactly. Go ahead.
No, because the reason for the epi or the steroids was that it was already ordered. It wasn't ordered in response to anything having to do with the transfusion, or that it was ordered maybe after the transfusion started, but for another condition.
But if you're doing this for surveillance, Ira, can't the reviewer just tell that reason and not have to?
Well,
the reviewer
abstractor is not a clinician who's answering the question.
Yeah, they're not supposed to use a lot of judgment. They're supposed to answer a lot of yes/no questions, or questions that give a lab value or something like that. So then the person would be looking to see if it was ordered for another condition other than the one that is this in the blood module or is this a drug issue?
Blood
module. So because we have a similar thing in the drug situation. So if it's being given for another reason, or if it's a pre-existing order, it just happened to be given temporarily right after the blood, we don't want to mistake that as a blood event. So that's why we put this in, because we were getting false positives.
Yeah, and this is Henry, and I'm looking at the commenting tool on the NQF site right now, and under blood, definition of event, 113 is transfusion reaction, and you find it either by notation in the medical record or treatment of a blood transfusion reaction treatment indicated by either of the following. And the first one is administration of epinephrine or corticosteroids or acute respiratory distress requiring institution of either ventilator support or oxygen. So,
Bingo.
Yes, I think so. Let me just to finish up. So in other words, it looks like the abstractor would be looking at the administration of epinephrine to actually identify the transfusion reaction if there was no notation in the chart, and that may be why they're getting the false positives.
Yeah, exactly.
That's exactly right.
So this would be to tell the abstractor, okay, look, if it's ordered for another condition or it's a pre-existing order before the blood was given, then don't use that to trigger the notation of a transfusion reaction.
Right.
Amen.
This is Matt. One question. So we're focused on the word, is it administered or ordered? That's two different things, too. Like I can have it on my med profile that, for whatever reason, I appear in order for epi and the corticosteroid on my profile is ordered, but it was given. So is that practice, too? So technically, should that be administered for another condition versus ordered, or?
Well, under the way it's written, 11321 says administration of epi and or corticosteroids.
Sorry,
and
you're
this
right.
condition would say, okay, it's been administered, but it was ordered for another condition.
Got it.
And that would be up to the chart abstractor.
So the medical record would have to clearly indicate that it was ordered for another condition.
Yeah, but presumably it would. And if it's, this would be an attempt to drive down the false positives, maybe not to zero, but at least to take a, major reduction in them.
So what's the sense of the group, that we should add it or leave it out?
David, I guess my only minor concern is, as mentioned by someone else on the phone too, is I'm sure this could rear its ugly head in many, many spots. So to me, it's almost, for add it here, then we have to really be judicious and look through the rest of the documents to see medication-related stuff that similar items are inserted for all the other things. Like naloxone with opioids is one example.
Yeah, we've been through that with some of the other ones. That's why I was a little confused at the beginning. I'm sorry about that. But yeah, we've tried to do those kinds of exclusions in several other places. Not that there aren't other ones remaining that we probably should do, but we have tried to do this.
And this one we know is causing confusion.
Yeah.
Right, and that would be, this is Henry, I would say, because what I'm hearing from Ira is that they're getting false positives, so it would be good to do something to diminish those false positives.
And couldn't we not let the phenomena of false positives cue us to where it's needed as compared to making a blanket decision now or generalizing this? Thank you.
So are we in agreement that we'd add these to deal with a false positive issue?
Yes.
Okay.
Yes.
Yeah.
Okay, so let's make that recommendation then.
Okay, thank you.
And then let's move on to device. And this is an issue we've discussed many times over the years. Recommend separating out HIT from other medical devices or equipment that are used in patient procedures. They have very different failure modes and very unique impacts on patients. We've talked about this a lot. Thoughts of everyone on the committee?
Well, this is Henry. Again, I'm looking at the outline from the commenting tool under devices, and so it starts with type of device, which in the fourth one is HIT device. And again, this is for an abstractor. And then next was type of event. If I